So let's move to our next case. This is a 50-year-old woman with a very significant family history. Her sister suffered of terminal stage pancreatic adenocarcinoma. Her father suffered of breast cancer, hepatocarcinoma, and her aunt suffered also from breast cancer. Because of her family history, she underwent a few months ago a computer tomography that revealed a cystic lesion in the tail of the pancreas. As you may see in the images, this lesion was about 20 millimeters in size and did not involve the main pancreatic duct. The main pancreatic duct was not dilated and there was no lymph nodes present. The lady, the patient, is today scheduled for further echoendoscopic evaluation through EUS and potential FNA function of the lesion. Let's join now Dr. Palazzo and Professor Eisendrath, who will perform the procedure.
Here we will start, in fact, the examination in the same place. So I find always the heart, because it's easy, it's always anterior. Then I push down, I find the liver, and now I will not try to find the aorta, but I will try to find the portal vein, follow it till the area of the hilum of the liver, and if we push slightly down, we will be at the level of the right part of the body of the pancreas, and I will try to follow after the pancreas.
And this technique may be used when you have a patient with an atrophic pancreatic body or tail, and it's a way to identify the aspect of the remnant pancreatic parenchyma, which is always visible between the probe and the portal vein and the circumference. That's what we will demonstrate now, I think.
Exactly. So this is the portal vein. And if I am able to turn slightly clockwise, you see the portal vein is going outside from the liver. So we are just at the level of the hilum, and you see just above, this is the hepatic artery, just there.
Yes. And if you push a little bit, this is the hepatic artery.
So I can show you that this is real thing happening. So you see, at the inferior level, this is the portal vein, and you see this is a twilight effect near the transducer, which means this is the hepatic artery. So now, and you see, so I try to align the portal vein, and if I push slightly here, I arrive just below my transducer at the level of the pancreas. You see with the pancreatic duct.
And the tissue which is always here between the probe and the circumference that you show
just before
here,
yeah, we have
it's always pancreatic tissue.
And you see we have a very nice image of the confluence. It's a Y letter, like a Y thing, just there. You see?
With the portal vein here,
portal vein
here,
and below
and the superior mesenteric vein.
Yeah. So from this part, I can turn clockwise. I will increase the size to have a better look. So, yeah, here just, so this is now we are at the level of the aorta, but just there, this is the pancreatic tissue, and we will try to follow it till the tail. So I have now to withdraw the scope, you see, to keep it at the center. And you see, as I am turning my shoulders, turning my hand, torquing the scope, I try to keep it at 6. And now, you see, we arrive and we see the lesion we need to find. And you see where is the arrow, it's the spleen, okay? So when this lesion is really 2 centimeters, he has like homogeneous anechoic liquid at the center. First, just before, for sure, you have to measure it. And the first thing I do in this case is try to see what is where is the pancreatic duct with this thing. And you see, we see very well the pancreatic duct there, and we will try to see if there is any communication with this ductal system with the lesion. So I turn clockwise. I see that the PD is coming up and very far, and you see, I see nothing communicating. You see, I do movement from one side to another side, one side to the other side, and you never see something relating the cyst to the pancreatic duct. And after, you have to look to the wall. There is a little wall. You have the parenchyma, normal. You have the anechoic. But if you look very carefully, you have something in between. So you have like 1 millimeter space wall. We say mucinous cystadenoma, lady, tail, the age, non-communicating with the wall,
Yes.
and maybe debris or wall thickening. So mucinous cystadenoma. And the second one, I would say, cystic neuroendocrine tumor. I have taken a 90 gauge needle because if it's mucinous liquid, sometimes it's really thick and difficult to aspirate. Pulling back the scope to be just at the good level. For sure, I will try not to cross too much pancreas, not crossing the duct, because it's in a 19 gauge, and if you cross the duct, you may have issue. Yeah. I put just small amount of Doppler in order to be sure there is nothing in between. So you have nothing, you see. I push slightly, you see the needle against the wall of the lesion. I remove the stylet a little bit in order to be very sharp. And then I enter in it like this. Okay, we are here. Aspirate everything, and you see, it disappears. You see? There is a small amount of blood. I am moving just a little bit the needle, you see, to completely collapse the lesion. And then after I will do just really small movement in order to have some material from the wall. You see, I don't move it a lot, just not crossing all the lesion, just move it to have cells. And okay, it's almost done. Okay. I put the Doppler one time. I don't have any hematoma. You see? Nothing special happening. So this is finished. Viscous.
Not very viscous here.
So
I'm a bit afraid to use it to do the string test and lose some of
material. I'm sure this is not.
Maxime and Pierre, just a small question, because on this specimen we want to have an cytology and we want to have lipase and CA measurement. So you have a process to do a centrifugation and to separate, to send it one to the lab of chemistry and the other one to the lab of pathology?
I don't know. It depends on, in my unit, we have to ourselves separate. Okay. Put some in biochemical analysis and the other in cytolite. I don't know why this is working.
We organize the thing that, particularly for this kind of situation where we have a quite limited quantity of liquid, we send all to the pathologic department. They are doing the centrifugation. They keep the solid part and they send the rest for the chemistry analysis, for the lipases, the CEA.
So that's very important. I think that because
that you know exactly the process of this material. Yeah, for sure.
So mucinous cyst is unlikely, no? In consideration of this fluid.
Based on this, for the moment, you see it's moving like nothing happened, and there is slightly amount of blood. And it's infrequent that you have this kind of blood in a mucinous cyst. It's more likely in neuroendocrine tumors or maybe cirrhosis adenoma.
Okay, thank you very much, my friends. Very good demonstration.
Thank you.